talking about today is why family matters to population health, and not just to the PCMH, but to the larger efforts that are being made to control costs and to serve the large populations of people. When we're talking about what we know from the research about families and health, and what steps we can take to both help patients and families live higher quality lives, but also how do we integrate family members into the integrated care team. And we'll talk also about what are those barriers that have made integrating family caregivers into the care team such a challenge, and even at this late date, in my opinion, it's still very hard for family healthcare professionals and social service professionals to really embrace family members fully. And then I'm going to turn it over to my colleague, Dr. Hung, to talk specifically about the program that he's developed in New Hampshire, in which he's really embraced family members as part and parcel of the health care that he's provided for frail elderly. Next slide, please. So I'd like to start off with a personal story. This is a picture of my father and grandmother. This is 1942 when my father graduated from the University of Pennsylvania. He's dancing with his mother, and my father was the oldest child in my grandmother's family, and was really the apple of her eye. As you can see, the look on her face, dancing with her son was really a big deal. My father was very close to his parents, went and fought in World War II, and then came home and moved back into his parents' home and didn't become independent from them until his 30s. Next slide, please. So here's a picture of my father on his wedding day with my mother. Don't you love my mother's dress? This is 1957. So my father was age 36 at this point, and had been living at home with his mother until then. Next slide, please. And here's another wedding day picture. There's my father on the left, and my mother in the middle, and my grandmother in between. And that, in fact, is where she liked to be. My grandmother was very covetous of my father, really competed for my father's attention with my mother, and injected herself in their relationship whenever possible. Next slide, please. So then when I was 14, and I'm the guy on the right with a mop of hair. Next slide, please. And my father at that point was the age of 51. My father, unfortunately, developed brain cancer. And during the year during which he was fighting cancer, unfortunately, he and my grandmother then fought about every medical decision that they could possibly fight about. They fought about where my father was going to get treatment, what type of treatments he was going to have. My grandmother had read about this experimental treatment for brain cancer in California, literally wanted my mother to sell our family home out, in Queens, New York, and move the family out to California so my father would have the best chance of surviving. And my mother, who had obligations not just to her husband but to her own parents and to her children, said no to my grandmother. And consequently, my grandmother never forgave my mother, blamed her for my father's death. And then from the day my father died in 1973 until the day I got married in 1990, 17 years later, my mother and grandmother did not have any contact with one another, and then finally saw each other again at my wedding. So I always bring the story up by way of saying that families can be brought closer together as a result of medical crisis. They also could be could suffer terrible schisms where family members don't talk to one another literally for decades, and this really adds greatly to the suffering caused by illness. Next slide, please. In more recent years, my mother got remarried, and her second husband, unfortunately late in his life, developed Alzheimer's dementia. This is a picture of her with him in his nursing home, and here she is feeding him. Next slide, please. And more recently, my mother herself has developed dementia, and she herself, after being in an apartment close to me for the past 5 years, she very recently went into a nursing home. And here's a picture that my son just shot of the two of us about 2 weeks ago. I've been in the caregiver role with her for a long time. What I would say is that it's these personal stories that many of us have that really inform our work and then help us really understand the impact of illness on families, and also on our efforts to help our family members who are ill manage their illnesses, how important our efforts are for the quality of life our loved ones have, but also for the clinical outcomes that healthcare professionals are able to produce. Next slide, please. So, we come to this issue of why does family matter, and I would argue that family matters more than ever in healthcare, and I would say that our traditional American healthcare system has been extremely patient-centric. It really reflects the kind of individualistic ethos of our culture as a whole. But despite that, there are certain factors that are falling into place that are placing a greater emphasis on families. So one is that we have a rapidly aging population. And about 13% of the current population is over the age of 65, and that's going to shoot up to 20% by the year 2030. That means 1 in 5 Americans are going to be technically senior citizens, which it's the first time in history anything like that. With the aging population, we have a rising incidence of chronic illnesses, as well as people living with functional limitations. They may be walking with a cane, have hearing deficits. They may be unable to feed themselves, and that means that they need help, and that help is primarily coming from family members. And the other major factor is that with the Affordable Care Act and other changes with healthcare reform, we have decreased lengths of hospital stay, and that means that and we have a very strong emphasis now on preventing hospital readmissions, and families are now being seen as key to keeping people out of the hospital. So I would say that a lot of the population health efforts that are being launched in my health system, Dr. Hong's health system, many health systems around the country to reduce hospital readmissions, a lot of them are hinging on how well patients do in the community with the help of family members. Next slide, please. When we look at the literature on families and health, there are really two very separate traditions that I want to outline very briefly. One is going to be very familiar to anyone who's been a member of Collaborative Family Healthcare Association for a long time, on what the family systems medicine movement. And the idea of this started in the 70s and 80s, was to take the insights of family systems theory and family therapy and apply them to physical healthcare. And the major progenitor of this movement was psychiatrist Don Block, who not only was a co-founder of Collaborative Family Healthcare Association in the early 90s, but in the early 80s founded a journal that was then called Family Systems Medicine, is now called Family Systems and Health, and as many of you know, that is the home journal for the Collaborative Family Healthcare Association. Other major hallmarks of the family systems medicine tradition was a publication of a book called Family-Oriented Primary Care by Susan McDaniel and Tom Campbell and others in 1990, and then republished in 2004. And then the medical family therapy movement, which was again founded by Dr. Susan McDaniel, along with Jerry Hepworth and Bill Doherty in the early 90s, followed by works by John Rowland and Lorraine Wright and other seminal thinkers in medical family therapy. All of these provided us with tremendous insights to how family systems and medicine work together. Next slide, please. At the same time, there's been a separate and parallel tradition, which has now gone under the heading of family caregiving. And this is a multidisciplinary research and practice tradition that's gone on for over 30 years. That is not, it does not stem from family systems theory, but is in fact kind of based more on stress theory and just basic scientific research. Originally, was very focused on dementia, the works of people like Anna Schenzel and Steve Zaret. More recently, Joe Gaugler and Bob Kane and their work. And this is work that's looking at family caregiving writ large, and not so much practice, but how are family caregivers doing. The two pictures here are two of the major leaders in family caregiving, both of whom have been CFHA plenary speakers at conferences in the past. On the left, we have Suzanne Mintz, who is the co-founder of the National Family Caregivers Association in the 90s, and that organization is now called the Caregiver Action Network. On the right, we have Carol Levine of the United Hospital Fund of New York, whose Families in Health project is one of the most important family caregiving leaders in this country. They've done excellent work advocating for caregivers, developing policy to help caregivers, and actually developing action steps clinically to help caregivers. Next slide, please. When we look at the most recent poll data on family caregivers in this country provided by the National Alliance for Caregiving and AARP in 2015, there are 43 million Americans who in any given year engage in some form of care for a friend or family member. And as you would guess, this is a number that's been increasing steadily over the years because of our aging population and also because of our medical advances. More Americans are living longer with the kinds of diseases that would have killed them long ago. People are living longer with heart disease and stroke and dementia, but these are not folks living longer whole and self-sufficient. They're living longer with functional deficits for which they need help, and that help is primarily coming from family members. Next slide, please. This is 43 million is a very heterogeneous group. It includes about a quarter of them, believe it or not, are millennials. This was a big surprise in the 2015 survey. These are also folks who have a wide range of reactions to caregiving. So according to David Roth in the 2009 study, about a third of those caregivers said that they don't have any strain for the caregiving that they're doing. About half of them said they have some strain, and a small, about 20% of them say they have a lot of strain. What we say in general is that family caregiving causes strains and gains. The gains include things like personal and spiritual growth, and that in general our job is to help minimize the strains and maximize the gains that people experience caring for a loved one. Next slide, please. In terms of some of the strains, Rich Schultz of the University of Pittsburgh has done excellent work in this area, has really found that especially dementia caregiving is associated with insomnia, depression, anxiety, musculoskeletal problems, and that because a lot of dementia caregivers tend to neglect their own health, they unfortunately have a higher mortality rate when living with diabetes and hypertension than non-caregivers with the same chronic illnesses. Next slide, please. But there has been more research, again done by David Roth at Johns Hopkins, more recent research, which has found that rather than caregivers having a shorter lifespan, that in fact some caregivers or many caregivers may have a longer lifespan. That Roth found that it was an 18% reduced rate of death compared to non-caregivers. And so we have two very different sets of data, which I think we're still trying to reconcile. Again, the major point here is that caregiving brings strains and gains. Next slide, please. When we think about what family caregivers do in healthcare today, and we said in our description of this webinar that caregivers are the front line of American healthcare. We have a list of different roles that they're playing, as you can see on the screen here, and I just say that caregivers wind up doing hands-on attending work. They do driving. They're doing technical interpretation. They're coaching. They're being a case manager. They're administering all kinds of different medications as well as other interventions at home. We ask an enormous amount of our caregivers in helping keep particularly frail elderly patients at home. Next slide, please. There is a broad and various research from different disciplines about what is the impact on how a family functions on patients' clinical outcomes. And I've just cited a few studies here, and you can look them up on your own. But essentially, if you can think about any chronic illness, there is a study or two that will say that how family caregivers do will have an enormous impact on how patients fare with their illnesses. This includes diabetes and HIV. It includes things like Jennifer Wolff's work with primary care visits. When family members are present in those visits, then patients are much more satisfied with the visits, and so are physicians for that matter. Next slide, please. Probably the most important study in family caregiving is this Mary Middleman study from 2006, where she found that an intervention, a psychosocial intervention supporting caregivers, increased caregiver well-being, and managed to forestall nursing home placement of patients with dementia for nearly 2 years. And if you consider that the average nursing home costs about $90,000 a year, an intervention like this is a public health savings of over $150,000 is pretty extraordinary. So then we look at, so what do caregivers need, family members need, in order to be better integrated into the healthcare team? And you can see the list here. I'll go through them one by one. Next slide, please. So maybe most importantly, what caregivers need from us is they need to be acknowledged. When we have patients in our offices and a family caregiver with them, we need to acknowledge who that person is and what their contribution is to the healthcare team. Suzanne Mintz, who I mentioned earlier, is someone who's now been advocating for actually identifying patients, family caregivers in the patient's chart, so that that we begin to recognize that so much of our health care for chronically ill people is dyadic in nature. Suzanne Mintz has a very interesting essay where she was talking about chronic illness in her own family, where she wrote, "We, the family and Mintz, need clinicians and payers to view us as a single unit of care." I mean, the family systems medicine people have been saying the same kinds of things for decades. Next slide, please. We need communication systems that really enable family caregivers to work closely with the team. And in this day and age, what that means is we need portals which all of our electronic medical records to allow family members to speak directly to our healthcare professionals and to have access to information, maybe even to correct incorrect information that the healthcare professionals may have entered into the chart. Next slide, please. We need family caregivers to have some modicum of decision-making power. That we want to have not just patient goals in the patient's chart, but we may want to have their family caregiver goals, and that we want to consider family caregivers as lay members of this team, so that they are at the table when healthcare teams are making decisions. Next slide, please. We want to incentivize financially family caregivers, and this is true in other countries, including England and Sweden, where family caregivers are paid for their work. We are beginning to do this in this country, where we are paying caregivers to take on some of the home health aid work that otherwise society or the family would be paying out of pocket, and this should produce measurable results. Next slide, please. We want to have assessment in place in all healthcare settings so that we're assessing how family caregivers are coping, but maybe most importantly, are they willing and able to perform the tasks that we're asking them to perform for the patients with chronic illness that we're treating. Next slide, please. Many caregivers are de facto case managers. They're bringing information from one office to another. They're dealing with our fragmented healthcare system by really taking on a kind of integrative communication role. And we want to acknowledge them for this, especially when it comes to transitions of care. When patients move from the hospital to home, hospital to nursing home, family members have to be empowered to share information and to coordinate care. Next slide, please. We want to provide caregivers with training and support to better enable them to do their jobs. Next slide, please. And we want them to have not just EMR portals, but all the wearable technology, all the communication technologies that are now coming online to enable them to really to communicate their observations and their concerns, to be in contact with the healthcare team in a seamless way, and to be able to take direction from the healthcare team to provide hands-on care in the home or changes in hands-on care in the home if needed. Next slide, please. So what are the objections to family involvement? Well, again, it's a wonder to me, but there's still many people, many healthcare professionals that feel uncomfortable involving families. They say things like caregiver involvement undermines patient autonomy and confidentiality. To me, this is really a misinterpretation of HIPAA's intent. They say it alters the quality of the patient-professional relationship. I think that there may be something to this one, but I think the patient-professional relationship is already changing because we're moving towards team-based care. And we're asking family members to be part of the team. So this is in flux. They say that working with families takes additional time, and I think that in large part is true, but I also think that the payoff is worth that additional time in improved clinical outcomes. Next slide, please. And then we have healthcare providers who say, I don't want to get in the middle of a conflict between the patient and family member. And I would say that that's a problem, though all of us in the healthcare professions ought to be equipped to help family members and patients find common ground and to pull in the same direction. When we pull in the same direction with them, then we're really going to have the best chance of positive clinical outcomes. And then the time I spend with patients, family members is unreimbursed. I think this is an objection that's going to be addressed as we rapidly move to more value-based financing in healthcare, where we are going to be paying for outcomes. If we find that involving family members makes a difference in terms of our clinical outcomes, then we are going to embrace them wholeheartedly. I'd like to now turn this over to my colleague, Dr. Hong.
Hi, everyone. Thank you very much, Barry. First, for inviting me to present with you today. To those that may not know me, my name is Hyun Hong. I'm a family physician currently in Concord, New Hampshire. I'm currently pursuing a second residency training program at the Dartmouth-Hitchcock Leadership Preventive Medicine site. I'm really excited to join you all. There's many members of the Collaborative Family Healthcare Association whose work I really have admired and followed over time. Just to name a few, Suzanne Mintz, John Rowland, Mark Jaffe, and Barry himself. Now, I'm not here today to tell you what to think or do, but rather just to share one team's approach to supporting family caregivers. Hopefully some of the lessons that I can share that we learned along the way may be translatable to your own organizations. Next slide, please. So as many of you in the behavioral health world may be familiar with this, this is an Ecomap. I completed this when I was a second year in family medicine residency. It was when I was first introduced to concepts of systems thinking, organizational development, and complex adaptive theories. My understanding of this all began with John. John was a Vietnam War vet. He was an accomplished guitarist. He even played in a band for the majority of his life. Back in 2011, he unfortunately had a stroke, and this was tremendously challenging for him. He was no longer able to play the guitar. I think in addition to that, his other medical complexities, including AFib, atrial fibrillation, history of myocardial infarction, COPD on home oxygen, histories of heart failure, they've all contributed significantly to his personhood. His wife, Dee, who he married over 50 years ago, I would always see her coming into the office with John. She always called if they were going to be late. She also called if there were any concerns at all about medications or other types of concerns. When I first visited John and Dee in their home, which is a mobile home 30 minutes away from my site, it was really then that I realized just how involved Dee was in John's care. Every day she performed vital signs. In fact, she brought me 2 big binders of the vital signs she performed over the last 3 years. She helped John, who was over 150 pounds heavier than she was, weigh himself and help him with ambulation and making sure that he did not fall, knowing that he was also on Coumadin, a blood thinner. She also provided meals that were the recommended diet for someone with history of heart disease and history of CHF, congestive heart failure. I also saw her always supporting Ron and John in traveling with him to labs, imaging centers, and specialists. Next slide, please. So, but what about Dee? Now, what I did not mention to you all in the last slide was that Dee was also my patient. What I had noticed while so active in John's care, I've noticed a pattern of Dee not coming into the office, missing her appointments. In fact, one time I sat down with her wanting to interview her and get a better understanding of the life of a caregiver. I recognized that by the end of our interview, over 90% of her responses were still all about John. There was a moment when Dee had a profound impact on me and also my interest in caregiving. Back in 2014, Dee was hospitalized with a COPD exacerbation. Dee was also on home oxygen along with John. One night, John's oxygen tank did not work, and as a result, Dee had given John her oxygen. When I visited her in the hospital, she said she did not know how that would impact her own breathing. She said, and I quote, "I thought he needed it more than I did." It was really that statement that she had made that made me realize how significant caregiver neglect can be. Also, I realized that to focus on the patient, we need to approach this from a different perspective. Next slide, please. So, as we all like to do in the medical field, talking about a patient case, I thought that it might be interesting to show you how we may potentially approach Dee differently if instead of the family caregiver label that we approach her as the patient. So Dee is 68. She's a Medicare patient. She has over seven chronic conditions, including COPD on oxygen, heart disease, diabetes, anxiety, depression. She's on over 10 daily medications. And if the next slide, please. So one of the interesting things that I learned when I was looking and reviewing her chart was that no hospital admissions reported mentioning that she was a caregiver. The medical team's lens seemed to be strictly on her being a patient. At the same time, her husband, who was also hospitalized a couple times during that period, his reports often stated that his wife was a caregiver. But it made me realize that nothing was done in a way to help reduce the burden for Dee. Now, I did ask about the transition of care that Dee had experienced, and she did say that she received some good information on how to support John at home. But one of the statements that she had made was that she felt like she was a resource, like that she was a resource whose purpose was to serve the medical team. Now, seeing what you see on this slide, could the perspective of the medical team change to saying that the purpose, to one that serves the patient and the family caregiver? Next slide, please. The more and more I thought about this, I realized that we're, as an outpatient clinic, working in a vacuum. This is one of my favorite quotes by Paul Batalden, who is a senior fellow at the Institute for Healthcare Improvement. He said that every system is perfectly designed to get the results it gets. Is the result that we see because of the current outpatient setting with the short office visits, with the focus on just diagnosing and fixing for that individual. I began to ask and wonder whether healthcare systems could support activities that actually improve the conditions for the family caregiver. Anything that goes beyond a support group or beyond a packet of resources for the community. Is there anything beyond the walls of the clinic that who are already doing great work and offering tools to help caregivers? Next slide, please. Many of you may know the Quadruple Aim. This was the paper that was, I guess, the model that was expanded and published back in 2014. This expanded the Triple Aim to include the improved clinician's experience caring for the provider. I think this was a very positive step in terms of addressing the burnout for the medical teams and all the stressors from the changing care delivery models and the payment structures and the EMR. But it got me wondering, are we still missing another aim? Next slide. So this was really done for fun and to try to illustrate a point. Can we take a step further by encouraging healthcare systems to actively strengthen the conditions for the caregiver, in addition to the providers that are caring for the loved one? And next slide. So, as Barry alluded to with the information about the research that had been ongoing for the last 20, 30 years in this field, I began to try to understand some of the frameworks that some of the caregiver experts have published. One of them that I became interested in was the work by Dr. Schultz and his colleagues on the trajectory illness and stress model for caregivers. Based on his work, I adapted it to create this visual that already we know that the health of the caregiver declines, can decline with chronic caregiving. Next slide. However, can we potentially advance the family caregiver's resiliency by enhancing the capacity of the healthcare system in a manner that steps outside the walls of the clinic? Knowing the fact that not all things may or should be most appropriate to be led by the medical team, and likewise with the community organizations. Next slide. So my current clinical site for the past year as a preventive medicine resident has been with the Frail Elder House Call program. This is a home-based primary care program that provides primary care for frail elders in the community, both in community dwellings and long-term care facilities. Also, it is housed within the New Hampshire Dartmouth Family Medicine Residency, where we teach geriatrics to family medicine residents. One of the unique aspects, I think, for the Frail Elder program is that we have a team-based approach that integrates behavioral health and primary care. For example, we do, at times when appropriate, we go on team visits with an integrated behavioral health clinician. There's been moments where families found it very helpful. When I would discuss a medical issue with a patient, the integrated behavioral health clinician has had opportunities to provide some guidance and planning tools for the family caregiver. That's just one example of the type of work that we're doing at the Frail Elder program. Next slide, please. So for the remainder of the session, I'd like to focus on what are some of the steps and the approaches we're taking as a microsystem. First, within the microsystem, within our clinical team, and then across the mesosystem with other with organizations outside of our clinic walls, and then the macrosystem at the policy levels. With regards to caregiving, our mission is to partner with patients, families, and community-based organizations in building caregiver resilience. Next slide, please. So the first question that our team had began to ask was, who is the family caregiver? And as Barry mentioned previously, Suzanne Mintz, who has been a wonderful mentor of mine, asked this question over 5 years ago, just when the EMR was becoming recognized through the advent of the Affordable Care Act. She said, family caregivers are like undocumented aliens. They have no official status and there is no official record of their existence. I thought this was a very profound quote that she had written and published on. Next slide, please. So what our team began working on was trying to identify the caregiver. This, what you see in front of you, is a as-is process map of how different providers and staff at the Family Health Center, where the home visit program is housed within, try to identify who the family caregiver is in the outpatient electronic health record. This is just our system uses centricity, and different EMRs may have different functions, but I think the common theme that I've realized was that many outpatient electronic health records systems do not have an identifier field. Some of the interesting feedback that we've received was that providers and staff asked questions such as, is the DPOA the caregiver? Is it the emergency contact? And the next slide, please. So with the team, with the help from IT services at the hospital, we were able to create a caregiver identifier in the outpatient EMR. Next slide, please. And you see it in front of you. This is actually a part of the Medicare Preventive Service form. And this is part of the risk form that we routinely, on an annual basis, ask questions to the patient. And the new entry here is that before there was just the emergency contact, and now we actually have at least a caregiver identifier field that we can query and begin to address. Next slide, please. Now, in addition, one of the elements or the approach that our team felt was important was that we partner with family caregivers of our patients, but not necessarily in a way to say that we're doing family engagement, but to authentically to drive at the root cause and see how we can learn and support the caregivers that are doing important work. It was a way for us to not only acknowledge that factors outside of the office affect health outcomes, but that we were trying to actively participate to improve them. Now, the caregiver teams provide us routine feedback. They also set the priorities, and they also approve of the strategies. This is very similar to the co-production model that some of you may be familiar with. Now, one of the first priorities that our caregiver team had identified was that they needed help in planning so that they don't burn out. Next slide, please. So with the priority set by the family caregiver, we began to look at how can we help with that question. And a lot of it ended up being going into the community, just going and seeing who is already providing this type of work and providing the resources. What can we do beyond the resource package we give of the 30+ different services that's available for caregivers. So our team began to become active as members of AARP. We also began to shadow this. A couple of the members began to shadow the ServiceLink Resource Center, which is a area agency for aging. We also began to partner with and learn about some of the ongoing works by the UNH, which is the University of New Hampshire's Center on Aging and Community Living. Next slide, please. One of the tools that we learned by exploring what was out there in the community was this very interesting tool. It's the Navigating Choice and Change in Later Life program that had been developed by Patty Cotton and Sue Fox. They're both leaders in the field of aging and disability. Now, what this tool did was to help with planning, and what I mean by that is it identifies persons' preferences, strengths, capacities, and has a very interesting framework of helping that individual actively shape their futures. Next slide, please. Now, at the macro system level for policy, we realized quickly that we can't really reorient the healthcare system to support family caregivers without participating in the advocacy work that's ongoing. So our team had been supporting and being involved with the draft of the CARE Act, which is an act that it's the Caregiver Advise Record Enable Act, where pretty much inpatient electronic health records needed to identify caregivers in the inpatient setting before a patient gets discharged from the hospital. The name of the family caregiver is recorded. Also, upon discharge to another facility, the caregiver needs to be notified, and then the family must be provided live instruction of the medical tasks that need to be done. So this is now in effect, and it began on January 1st, 2016. Next slide, please. So I'd like to share with you one of the slides, one of the visuals that a small coalition of seniors and I had come up with together. And again, it kind of brings the point of the importance of advocacy. This group, this very energetic group that consists of semi-retired or retired individuals in the community, we gather every 2 weeks and we work on problems such as the question that our caregiver team had asked, which was, how do I plan? This senior coalition group also asked the same question. That question mark you see in the middle is really the fact that seniors go to very very different centers in their daily activities, whether it be the primary care office, whether it be community centers, YMCA, and in these organizations, when they visit, there's no real clear guidance on where caregivers can go to. The connection to the community resources that's available. So our team right now is working on an advocacy project to support ServiceLink, which is that area agency for aging, and informing some of those centers that that seniors frequently visit. Next slide, please. So how does this all come together? I think a lot of it ends up just having caregivers that can serve as advisors, identifying the priority, and then listening to them and then learning from them. Next slide. And how does this all translate to action? In the microsystem currently, what we're working on right now is a direct referral to area aging resource centers for patients and families who, for those that clearly just want to connect to someone that can help navigate the community-based resources out there. At the mesosystem level, we're working on a brief intervention process that incorporates person-centered tools by integrated behavioral health clinicians in the team to be able to use some of these personal planning tools for family caregivers when they feel like it's important and maybe helpful as a therapy. For the macro system level, the we're working with coalitions in the community and advocating. Current project right now involves going to the different primary care practices and asking if they know about the Area Aging Resource Center and what they do. What I learned was that over time was that for kids, for pediatric patients, if we identify a child with a developmental delay, positive developmental delay screen, we're very quick to be able to refer them or to connect them to community-based organizations immediately. But for seniors, I think that there is a gap that we're not really providing all the resources or at least the resources that they're seeking in a manner that's most effective. Next slide, please. So ultimately, what I've described today, it's really trying to get at family-centered care and also preparing for population health. In the microsystem level, how do we change our mental model from the illness to prevention? For the mesosystem, how do we partner with organizations so that we become we can create proactive pathways to support caregivers? And then in the macrosystem level, how do we begin to invest in long-term strategies through policy involvement and that aspect? And last slide, please. So really, I think that, as Barry had alluded to again, the timing is everything. I think this is a very exciting time in the healthcare landscape to focus on family caregivers as we transition towards population health and value-based care. I'd like to end this presentation by just quoting one of the founders of the Family Caregiver Program at Baylor Scott and Whitefield. This Family Caregiver Program is very unique. He had said that improved population health is unlikely without greater attention to the role of family caregivers, and the platform of population recognizes the full value of family caregivers. And to close, again, I think it's important that it's important to identify the family caregiver, to listen, learn, leverage, to embrace as collaborators, and then get involved in the family caregiver advocacy. Thank you very much.
Thank you, Dr. Hong, and thank you, Dr. Jacobs. We do have a few minutes left in today's webinar to field a few questions. Again, for those of you on the call who might want to reach out to Dr. Jacobs or Dr. Hung, in the navigation bar on the right-hand side of your screen, there's an opportunity for you to type in any questions or comments about today's presentation. Also, if you are interested in asking those or making those comments verbally, there is a small green hand or a small yellow hand that you can raise next to your name in the attendee panel. And if you'd like to do that verbally, I'd be happy to unmute you. And you are welcome to ask the question or make a comment. While we're waiting for questions, Dr. Jacobs, do you have any last comments you'd like to make?
I just would like to say that I think that the work, as Dr. Hong pointed out, the work of supporting family caregivers and integrating them in the healthcare system occurs on multiple levels. It's what we do in our primary care offices, in our community-based population health efforts, and then obviously it occurs on the larger political legislative stage, and that's where we begin to shift the health care system to one that's more family-centered. I think that a lot of good work has been done on the very basic ground level of how do we run a family meeting, how do we communicate with family members, and all that is great. And more healthcare providers need those skills. but as Dr. Hong pointed out, we need to be thinking in broader terms of how do we work with family members in the home, in the community? How do we link them with community resources? Break down the silos between healthcare and social services, because that's when we're starting to have systems in place that fully support family members as full-fledged members of the healthcare team.
Excellent. Dr. Hong or Dr. Jacobs, we do have one question from Tina Kenyon. She'd like to thank you both for the presentation and asks, what do you both see as the most significant challenge in this area in the short term?
Hyun, you want to take that?
Sure. I think that's a really great question. I think in the short term, the reason why our team has been focused on the policy side at the macro level is that healthcare systems are not very quick to adapt. And what I mean by that is just take that CARE Act, for example. We passed that act. We helped draft that bill, which was passed by Governor Hassan in New Hampshire back in October, and it was supposed to go into effect January 1st, 2016. And at the same time, if you ask many hospitals, not all hospitals are realize that CARE Act was indeed passed. So I think the communication of information and also the transformation, it does take time for that to occur. So being active in the policy side, I think, is very important. Now, for the short term, to answer her Ms. Kenyon's question, I think the short term is just to get started. To instead of doing a very lengthy planning process, to just get involved in the community, I think that many members will be very surprised to learn and be able to help caregivers in a more, I think, a more meaningful way. I hope that can answer your question.
Yeah, and my answer to that question, Tina, would be that we still deal with very ambivalent attitudes on the part of many providers towards families. There are many who feel ill at ease with family members, who feel that family members are a hindrance to care rather than great contributors to the healthcare outcomes. And there are many providers who still work to marginalize family members, and that I think is it's going to require almost a generational shift as we move away from the patient-centric mode of healthcare provision to more team-based care, more systemically oriented care, and a type of care that sees family members as part and parcel of the work that we do.
Thank you, Dr. Jacobs, and thank you, Dr. Hong. Thanks to both of you for presenting today, and thank you to the audience for joining us. As a reminder, we will have another webinar scheduled in July, so please check back with our website then. And one last announcement, our registration for our annual conference, which is celebrating the many faces and places of integration in Charlotte, North Carolina, October 13th through 15th. Registration will open tomorrow, so we look forward to seeing all of you at that conference. Again, thank you for joining us today. Goodbye.